Lumbar plexus, again, spinal segments don't, I mean, not that they're not important, but that's a lot adding to what you already have already. So what we have here is the lumbar plexus, and hey, ilioinguinal, genital femoral obturator. Hey, these all refer to things that are kind of like if either referring to the pubic region or referring to the pelvic girdle or the leg, right? So obturator, hey, remember that obturator foramen? What nerve do you think runs through that? This one right here. And then gluteal, hey, everyone knows where the glutes are. And then we have our femoral, sciatic, and pudendal. So the thing is that even though it's described as lumbar and sacral, they eventually do interweave. And it's actually, the thing is that they both go into your leg. That's why sometimes you see that term lumbosacral plexus. So sciatic and pudendal. So pudendal is very interesting. Pudendum comes from, I believe, a Latin term meaning shameful. But this is the one that so the perineum. This is the area between your genitalia and anus, and then your external genitalia, your bulbous spongiosus and ischiocavernosus muscles, also part of the genitalia. So this is why they call it the pudendal. It's like the shameful one because it covers all the things involving urination, defecation, and the private parts. So that's why it's named the pudendal. So that's, but again, it's not an anatomical term per se. It's like, it's not obvious at first, but once you know that root word, you know where the pudendal is. It's the sacral plexus right here. Now again, notice that these plexuses, they weave in and out of each other. That's why you might see that term lumbosacral plexus. And here we have all these nerves here, and pudendal we just talked about. Sciatic nerve we will cover, and the saphenous nerve. And actually, the sciatic nerve, it is typically the thickest nerve in the human body in terms of these peripheral nerves. So as you can see, it's thick here, and I mean, it can be like this thick. I think I remember in the anatomy lab at the medical school, I think they, what was the record? But yeah, sometimes it can get really, really thick in these sciatic nerves. So you can't, it's like probably one of the easiest nerves to identify in the human body, or easiest peripheral nerves. And then, yeah, so pudendal nerve, sciatic nerve, and then, hey, where do you think the sciatic nerve runs through? This is why we have the greater sciatic notch, or sometimes in some textbooks it's called the sciatic foramen. But yeah, this is why you have the big notch. Again, whenever you have a depression, hole, or some sort of notch, or something that's some sort of groove, something runs through it. And here we have our sciatic nerve, but not only the sciatic nerve, there are also other things as well. So sciatica is a condition related to the sciatic nerve. So it's radiating pain and or numbness to the spine to the back of the leg. Again, everything from the C to below is a mixed nerve. It's both sensation and motor. You both feel things and you control things. So typically on one side, right? Because again, you have a pair of these spinal nerves. So if one nerve of these sciatic nerves is being compressed, it's going to affect that associated side. And the other side, if it's not compressed, it'll be just fine. So often caused by, remember, your nerves don't like getting compressed. Your sciatic nerve is no exception. So things like hernia disc, like right here near the vertebrae, spinal compression of the nerve, or something called piriformis syndrome. So some textbooks or some sources, they kind of say like sciatica is the same thing as piriformis syndrome. The symptoms are pretty much almost exactly the same, but it's not the same cause. So they're related, but not the same. So piriformis is, again, one of those muscles right here in the pelvis. And what we have here is that piriformis muscle right here and the sciatic nerve running below it. And actually, this is the other interesting thing. I think I may not have had time to talk about it during the muscular lectures, but there are sometimes variations in the anatomy. So what we have here is a split sciatic nerve, and it's actually running through the piriformis. So people who have this, they're more at, so what is piriformis syndrome? Well, this muscle, sometimes depending on its tone, size, or sometimes it's just general anatomy and orientation, it can actually smash the sciatic nerve, causing the symptoms of sciatica, or sciatica-like symptoms. But if this nerve is running straight through this muscle, what happens when you contract that muscle? Well, it's going to squeeze the sciatic nerve as well. So that's another thing related to piriformis syndrome. And what's also associated, so remember, you have the numbness, tingling, and pain. And I think people say like it's sometimes, and that's why they feel it radiate all the way up their leg for the people who suffer from sciatica. But that's the sensation part. Remember, there's also a motor part. So foot drop. So this is what's innervated, or some of the muscles innervated by the sciatic nerve. Notice that we have our right here. So we have our sciatica and something called foot drop. So these anterior and lateral part muscles of the foot of the calf. So what are they going to control? Well, again, if they shorten, they're going to move the foot upward, and they're also going to move the foot out here and evert it as well. So the thing is that this peroneal nerve innervates the anterior compartment. So if you flex this, it's going to bring this foot up. But what if you have sciatica? What if you have a lack of motor control? Well, instead of flexing this foot up, you're going to have problems with flexing that foot upwards. So what does foot drop look like? I know it has this diagram, but here's a patient with foot drop. It's kind of hard to see from posterior, but they're going to show another angle. Now pay attention to I assume his right foot. And another pass. So notice that the right foot is the toes are almost dragging on the ground. So this is what is another classic symptom of foot drop, is if the patient tells you that they're tripping over each other or tripping over themselves. So notice that again, that right foot is dragging, the toes are almost dragging on the ground whenever they take a step forward with their right leg. So again, if that right foot is dragging, it's easy for that foot to catch and trip themselves. And this is why, because again, you don't really think about when you're walking that you're actually flexing your feet and how you flex your feet. But if you have a total lack of subconscious control or voluntary control of the foot when it flexes during walking, it's going to cause it to drag when you raise that foot up. So how do you treat it? Well, actually, don't worry too much about treatment in terms of memorizing this list. But what I'm getting at here, there are many ways. There are drugs, that anti-inflammatories, muscle relaxants as well. Physical therapy. Interesting thing is that by stronger core muscles, by improving the tone of muscles and other muscle groups, sometimes you can relieve pressure on nerves by increasing the tone so that they don't compress nerves. So that's why physical therapy is often prescribed. And chiropractic alignment, I put a little asterisk there. I think so. The thing about chiropractic is that it's become increasingly evidence-based. So chiropractic doctors, they said like you can move the piriformis or move the sciatic nerve out of or move it into alignment that doesn't get compressed as much. So I think they're still investigating that as well. So it's under debate, but I think it's gaining traction in terms of being accepted in terms of sciatica, but I think the jury is still out overall. Now, peripheral neuropathy is not, it's just a general condition. Actually, we don't really have too much time, but many potential causes. So don't memorize this list, but many things can damage your peripheral nerves. Things like lesions, not having enough vitamins, infections, alcohol, type 2 diabetes. So many things can damage your nerves. And then what are the symptoms? Well, sensory symptoms, just like the other ones we talked about. So numbness, tingling, and pain, and sometimes even like sharp throbbing or freezing or burning pain. So if things are wrong with the nerves that detect temperature, yeah, they can cause false sensations of very cold or very hot. Or there are also special nerves called nociceptors that actually detect pain and carry sensations of pain. There's motor symptoms as well, so muscle weakness and paralysis. Again, most of your peripheral nerves are mixed nerves. So if you have problems with sensation, you're also going to have problems with controlling the muscles innervated by that nerve that's being damaged. And lack of coordination and falling. So diagnosis, they can do the nerve conduction test like in the median nerve during carpal tunnel syndrome, and electromyography. Actually, we don't have a video, so don't worry too much about that. And then pain relievers, again, you can do many types of drugs, even over-the-counter things like capsaicin cream and lidocaine patches. You can buy those without a prescription. Antidepressants sometimes, and anti-seizure. Remember GABA? That's the general inhibitory neurotransmitter. So if you have so sometimes they prescribe that to kind of reduce the pain signals as well. And diabetic, well, we'll talk more about diabetes next semester. So how can you check on the health of peripheral nerves? Well, we talked about things like electromyography and nerve conduction tests and other things as well. But how are detecting for Tinel signs in the case of the median nerve? But how else can you check?